to join this forum, and thank you all for getting online and joining us. So this is a prevention talk, and so I think we'll start with a quote from a cardiac epidemiologist. The idea behind the ROSE principle is that the largest number of cases of illness don't happen in those at high risk, but actually those who just have some risk. And the reason for that is just there's more of them that have some risk. When we talk about risk, we think about ASCVD. So the AHA have basically pooled cohort risk equations, or the ASCVD risk calculator, which remains the foundation of basically assessing for primary prevention of atherosclerotic coronary disease. So although all individuals should be encouraged to follow a heart-healthy lifestyle, estimating somebody's 10-year absolute ASCVD risk enables matching the intensity of the preventive interventions to the patient's absolute risk. So now we've all done this calculator before, either through the website or you can just phrase .ascvd on Epic. And what you come out with is a number similar to what we're seeing up in the right upper corner here. And so you get either a 10-year risk that's low, borderline, intermediate, or high. So I note the intermediate, that's 7.5%, seems to be the threshold, where we might make a decision on whether or not to recommend a statin in many individuals. So, and we all know that this is not a perfect sort of calculator, right? There's certainly cases where we plug in traditional risk factors or classical risk factors, which is what this is asking for to input. And the scores come out, maybe lower than we thought. And perhaps we're concerned that there's an underestimate here because, in talking to the patient, you've realized that they have some ASCVD risk enhancers that aren't accounted for by the usual, risk factors that we enter in these calculators. Things like, premature menopause, or they have a systemic inflammatory disease, or ethnicity could be a factor, if they're Southeast Asian. So there may be something about the score you're getting back that concerns you more, that maybe you're undertreating and we're underestimating risk. On the contrary, there's plenty of data, lots of real world data that show that, and just the opposite, that you're overestimating risk. This is a fairly large real world population of 307+ thousand people that are looking at the pooled cohort risk equation, right, the ASCVD score. And showing that it's substantially overestimates the actual 5-year risk in this case, adults without diabetes. And so in each of these 5-year predicted ASCVD risk categories in the chart here, the observed 5-year ASCVD risk is actually substantially lower than predicted. And so we've tried over the years to come up with ways to reconcile the limitations of the ASCVD scoring calculator. The predecessors to that, by the way, were ATP3, ATP4. So we've always had sort of these types of pooled cohort risk calculators, and we've recognized that they haven't been perfect. And so we've tried to introduce some novel biomarkers to sort of inform the gray zones, see if we can better discriminate the risk above and beyond those risk calculators. And so historically, what we've done is we've introduced biomarkers into the mix. Such as some of these you see in the diagrams here. We'll fillet open the LDL particle, and measure the densities of it, the type of pattern it shows. We'll look at lipid particles upon lipid particles, apolipoproteins, Lp(a), inflammatory markers, and then we'll use those in conjunction with the pooled cohort risk score, the ASCVD score, to help reclassify one way or the other, maybe, whether there's an underestimate or an overestimate of risk. What we found actually, over the years, and calcium scoring has been around a long time, that the calcium score, the coronary calcium score, appears to be superior for the prediction of atherosclerotic cardiovascular risk compared to all these other markers that I'm showing on the page, and some others as well. So what is CAC, or what is coronary artery calcium? So in the late 50s, coronary calcium was recognized in vivo by fluoroscopy. And so it's been described for a long time, more recently in CT. And so if you look at the calcified coronary, calcified coronary calcium represents approximately 20% of the total coronary plaque burden, right? So hence the more coronary calcium, the more atherosclerotic burden that's present, right? The other 80% of coronary plaque is fibrous, it's fibrotic or fibrous, or lipid-rich plaque, it's the so-called soft plaque. So calcium is going to appear in the early phases of CAD, and it's not just it's actually a measure of atherosclerosis itself, right? It's not just a marker of disease like the traditional Framingham risk factors, right? We're not marking disease, we're actually looking at the disease itself. So by CAT scan, right? So by CAT scan, coronary plaque can be picked up either as calcified plaque or non-calcified plaque, right? So the non-calcified would include the fibrous and the lipid-rich plaque, right? So I want to distinguish between the CT angiogram or the contrast CT scan and what we're talking about today, which is the non-contrast scan. So over on the left, I'm showing you some provocative pictures of, these fancy contrast version scans that detect both the calcified and the non-calcified plaque. And so these are the near equivalent of an invasive angiogram, where we can assess the degree of any coronary stenosis. We can use computer algorithms to calculate flow dynamics. This is not what we're talking about today, right? What we're talking about today is enhancing our risk prediction using a non-contrast calcium scan. So what we're talking about is a scan like the picture I'm showing on the right here, and that is basically a very quick, very low radiation scan that doesn't require much prep for the patient. They don't need meds for this. They don't get nitroglycerin for this. You don't have to beta block them for this. All they have to do is show up and follow a command to lie still for 5 seconds and basically and hold their breath until the test is done. So this is a non-contrast scan. And so when we get a result from the non-contrast scan, the best way we can kind of give you that result is to give it to you in the Gadsden units. And so most studies that evaluate the predictive value of CAC are using absolute values of the Gadsden score. The Gadsden score just sums the area and the density of the CAC, and basically gives you sort of 4 categories, which I'm showing in the table here. A score of 0 with really no identifiable calcified plaque burden, 1 to 99, mild disease, and then severe disease, over 400. And so that's the best way to think about this in terms of those categories. You'll see things on reports sometimes that'll also distribute it by age and gender and density, specific index densities. But the best way, I think the thing that I'd ask you to remember is just to remember these sort of categories, because the categories actually correlate very well with events, and that's what we're worried about here, right? We care about events. And so this is a busy slide, but I'm trying to make the point here. This is the MESA study, which is a large study, probably the best evidence we have to use these coronary calcium categories in terms of correlations with events. And so the MESA study looked at about 7,000 asymptomatic men, women across 4 racial groups without any known coronary disease, right? Coronary atherosclerosis. They followed them for 10 years. And so the figures are just illustrating the relationship between, your CAC category or your CAC score and cardiovascular events, right? Heart events that we care about. And nothing magical, the dark line is your CAC score is over 300, and you can see as time goes on, they're going to have the more events, and a score of 0, hardly any events. Ethnicity is interesting. It affects the likelihood of having CAC. In other words, Caucasian men and Hispanic men tend to have higher CAC scores than African American or Chinese men, at least in this data bank. Or in women, Caucasian women tend to have the highest CAC scores, and Hispanic women tend to have the lowest CAC scores. But even though the ethnicity affects the likelihood of having CAC, it doesn't influence the predictive value. The predictive value is actually similar amongst all ethnic groups. And it's similar amongst gender, and it's similar amongst age as well. So the predictive power as it relates to events is quite powerful across all these groups in a fairly large study here. In the same MESA study, the benefit of statin therapy is also significantly related to the CAC grouping, right? So with the benefit shown in patients with a CAC score over 100, versus not really any benefit for patients with a CAC score of less than 100. And I'll touch on that later. There are some exceptions to that, but I just wanted to touch on that. In this slide, this is data dating back to the ATP3. So this is the risk score that was sort of the predecessor to ASCVD, but I like this slide. And they're using the outcomes data to demonstrate the predictive capability of CAC CAC categories to reclassify, in this case, the ATP risk, right? And we've done this with MESA as well. And you can see using the CAC score, for patients that would otherwise be in an intermediate risk category based on their ATP3 score. The CAC score reclassifies a substantial number of patients into really a more accurate category. And it's this net reclassification that is what really drives the utility of CAC. And it seems to be superior compared to, in terms of predicting and reclassifying atherosclerotic cardiovascular risk compared to all the other sort of gray zone informers that I was mentioning before, the high sensitivity CRP, carotid intimal thickening, family history, and so on and so forth. So it's a powerful reclassifying tool, and the guidelines have recognized that. And so here's a clip from the ACC 2019 prevention guidelines. I'm going to just draw circles on a few of these just to show you the where we're going to intervene with potentially a CAC score, but I'll translate this to simple wording in the next slide. So again, as we're assessing risk, we're looking at patients who would potentially benefit from CAC in terms of helping us determine who would benefit from statin therapies. We're looking at intermediate borderline risk patients or patients that have some uncertainty in their decision making. So it's just translate it and make it a lot easier. Who do you want to potentially use a CAC score in? So patients under 70 years old, when the patients are borderline or intermediate risk, as an arbiter of risk, so that you can potentially reclassify to something that might be appropriate. Or if there's any uncertainty related to clinical decision making, or the patient prefers, they don't want to go on a statin and their number seems a little bit high, their risk seems high. So to guide lipid lowering therapy, and also we'll talk about aspirin a little bit later as well. So practically speaking, to play it out, how do you do this? So let's made up an example: 67-year-old Caucasian gentleman with hypertension, right? And running an ASCVD score on him comes out probably on the strength of his age and hypertension as a 10-year risk of 13.3%. Right, and so that would kind of obligate him to a recommendation of statin and potentially more, depending, and it would probably influence where you would set all his preventive goals. In this case, with the MESA risk incorporates the calcium score. In this case, it's a score of 0, and you can see that it just plugging that in actually reclassifies his risk from 13% down to about 3.9% 10-year risk. So again, in that scenario, it doesn't even meet the threshold for aspirin or statin. So it could potentially really change, the approach here. And so I want to highlight the power of 0 because I think it's important. I mentioned that that event rates seem to be very low when there's a CAC score of 0, and that seems to bear out for years, at least 5 years. There's a lot of data that goes out to 15 years. This is not an absolute. There's some newer trials that show that there are exceptions to this. Diabetics or folks that are active smokers, it seems like their event rates do seem to be a little bit higher than what people that don't have those risk factors and have a 0 score sort of shake out. But for the most part, the recommendation here is that if you have a CAC score of 0, because that means that your 10-year ASCVD risk is going to be low, then you wouldn't want to give them a statin. The guidelines recommend against a statin if your CAC score is 0, but you would want to repeat it, at least your risk stratification within the next 5 years, and see if that changes over time. If there are compelling reasons, again, it's not an absolute, diabetic, active smoker, then that's not, again, an absolute to not put on a statin. I found this in Up to Date. I thought it was, I've never seen this. This is their take on the power of zero. They call it they do a lot of sort of fancy statistics, but they call it the strongest negative risk factor. So the power of zero providing really like the strongest degree of individual de-risking available as compared to any other sort of traditional or novel biomarker. In the Jupiter data set, which is a trial of folks with high sensitivity CRPs that are quite elevated in statins, if you look at folks with a CAC score of 0, the number needed to treat is enormous. And so again, the power of 0, think twice before recommending a statin. In most cases, you won't need one. Picture is worth 1,000 words. I think one of the other strengths of calcium scoring is motivational. This has been seen in quite a few observational studies that just patients seeing, their CAC, either their score or actually seeing their CAC on an image that you show them, is helpful to better inform them and better enhance our discussion with them and better help make decisions regarding lifestyle changes and other modifications that would help in their preventive strategies. There's data on this, patients knowing their CAC score. There seems to be more compliance with statins. The same goes for aspirin. So I'll touch on that here briefly. Aspirin, we've reprised the whole notion of an aspirin a day keeps the doctor away. We used to, for a primary preventive strategy, just everybody would sort of get an aspirin, and then we would deal with the harm on the back end of that. We've tried to become a lot more discriminating in terms of who actually needs an aspirin a day compared to others. And CAC seems to be a great discriminator for that. The sort of party line or the guideline is, in folks, again, under 70 years old, using it for primary prevention of ASCVD. If your score is 0 or less than 100, regardless of your ASCVD risk score, wherever that shakes out, then aspirin's net clinical benefit doesn't outweigh the risks of aspirin. So you don't want to use aspirin if your score is less than 100. At the same token, if your CAC score is over 100, regardless of your ASCVD risk category, be it borderline, intermediate, or wherever you are, with shared decision-making, aspirin is warranted. So I think the conclusions are, that CAC scoring helps better risk stratify by reclassifying beyond sort of our pooled risk cohorts and other novel sort of risk classifiers. I think it's important to know in MESA, over 50% will have 0 scores. So a lot of people are going to have 0 scores. And so you got to, be sure that, we're not over-treating or under-treating, but over-treating is something that we don't think about as much, and really sort of look towards what is the benefit, of aspirin or statin in somebody who may have a score of 0, and as it relates to, the benefit risk ratio in terms of harm. And then improved compliance, I think, is another sort of wonderful feature of this technology. My final slide is from one of my mentors, Dr. Budoff. Of course, I spelt his name wrong. He loves this slide. He always shows it from in all of his CT talks. Superior doctors prevent disease. Mediocre doctors treat the disease before evident. That's kind of where coronary calcium fits in. And then inferior doctors treat the full-blown disease. So to order a calcium score, it's an EPIC order in radiology. Here's a link that I think will be stored somewhere, and the link will pull up this screen, and there's some there's actually a link there that you can click on how to order a CT calcium score. And that'll go on through radiology. This used to be a test up until this, I think, the end of this week, where it was out of pocket, $150. Insurance didn't touch this for everybody. That has changed. I think it's effective either November 1st or next week. I forgot the date offhand. I'll look during our break here. And so it turns out that most insurers are going to pick this up. It may require prior authorization. If there's insurers that do not, pick it up, then So it may require phone calls from the patient to the insurer, but it's changing. It's not a out-of-pocket automatic anymore. The test is now becoming insurer covered, and there's a CPT code for it. All right, and that's all I wanted to say. Thank you very much.
If you can go to the next slide, Stefan, that just has the code up there again, I think. Thanks. So there's a few questions here. Let me just kind of moderate that for you. First question, does the .ASCVD include a calcium score if the patient has already had one done? And I believe that's no. Do you know? Yeah.
Yeah, it's no. They're using the reference is the one from the ACC from Dr. Jeff, and so no. The answer is it doesn't. So what I showed you was the MESA 10-year risk. The way I did that was I just go to Google and I just type in MESA 10-year calcium. And
so you could put that, and you could put the calcium score into the calculator.
Yeah, I think that we should probably. I think it's a good idea. I have another form on this where I'll bring it up with the leads at Brigham and MGH whether or not it'd be a good idea to get a .MESA 10-year risk, because I do think I do it manually through Google.
Yeah, and do you know if there's a like last calcium score a smart phrase where you can pull that into the notes? Have you seen that at all?
Not, I haven't seen that last calcium score one.
Okay.
I think that would be, yeah, that'd be an interesting one. To just to riff on that too, you know, people are, if anybody asks, I can't see the chat right now, but you know, people always ask, so do we follow these serially? Should we just keep doing CAC scores? And so, so the party line on that is if your score is 0, you know, or it's a less than 100, then there may be some utility in repeating a test in 5 years as you're sort of coming on your re-risk stratifying. And so there's data to do that. And I think a lot of sort of experts throughout would all sort of agree to that. You know, if your scores are already in the intermediate or high range over 100, there's not a lot of enthusiasm to do that. You know, you've already sort of identified that there's a decent amount of calcium burden, and you know, every you know, a Gadsden unit is not going to help.
Sure. The next question is from Dr. Mayo. If the patient has a coronary calcification on CT lungs done for whatever reason, should they get a CAC score?
Yeah, so the CT scan is not, they don't run the software for a CAC score, even though it's a non-contrast scan. It might be, you know, they're looking at whatever. And so they're just doing a qualitative assessment. They're not actually running the software to get a Gadsden unit off of it, or they sort of merge the density. You know, I think that, I think it's a good idea. You know, I think you basically told the patient, you know, you had your whatever CT for, you know, your kidney or something, and they see some coronary calcium, you know, because they caught a little bit of it. You know, you're making a diagnosis of coronary artery disease, and I think that I think it's incredibly useful to then quantify that in terms of you know, the categories, because again, there's treatment implications and implications in the risk stratification. So I think it's a great idea. I don't know, you know, I'd love to see the day where you can go back and just kind of, and I'm sure it shouldn't be hard, just to superimpose then the software. You should be able to run it back with software to get your score, but you know, there's probably
a couple other questions. And before I finish the questions, I just want to make sure I just remind folks of Dr. Friedman's Grand Rounds Wednesday mornings. This Wednesday morning actually is the annual breast conference. It starts at 8 a.m. as opposed to 8:30. And then the following Wednesday, our president, Errol Norwich, will be talking as well, giving a grand round. So just to make sure I tease that for the Department of Medicine. There's a question here for people with borderline ASCVD and willing to take a statin, do you see any utility for getting a CAC?
So, and they're willing to?
Yes.
The utility could be that the ASCVD is an overestimate, right? And even though they're still borderline, right? And so, you know, it's, I mean, the downside is you may be treating unnecessarily, right? And so I always look, you know, and if I can go back on the slide here for a second, I think those, you know, in the guidelines, they talk about these risk enhancers, you know, and I mentioned a few of them, but if I go back on the slide here, over on the side, if I can get my my cursor to move the zoom. These risk enhancers, I do weigh a lot, in those, people with the family history, the things we can't account for that well, the inflammatory states. I do think that if somebody is borderline risk and they happen to have some of those and they're willing to go on a statin, I probably wouldn't get a CAC score. I think that, I think, again, it's just honing in on it. I think some people, most of the time, it's just people don't want to be in a statin. And that's where this helps us. If you've got somebody, like you're talking to a cardiologist, right? If somebody wants to go to a statin, the answer is yes. I'm not going to do something to erase that, so.
Couple other, how does the CAC correspond to a coronary angiogram? I guess what they're saying is, does it tend to overcall or undercall these plaques? And can we rely on that?
Yeah, so a CAC doesn't, so it's not speaking to the degree of stenosis, right? So calcium, as it shows up on a CAT scan, it has a bloom to it too, right? It almost has a little halo, right? A little shine to it. So as it's kind of superimposed on the diameter of a vessel, you could look like you have a ton of CAC there, but then you do an angiogram and the lumen itself is not at all compromised, right? But it doesn't mean that the risk isn't high, right? You may have negatively remodeled, around, and so you do have a lot of, lipid-rich, nasty plaque, just not obstructing the blood flow, right? And so the in any individual lesion, the amount of coronary calcium is not going to dictate, the degree of stenosis. And so, but the CAC score is just speaking of the total burden of plaque, calcified plaque, and that total burden, again, translates to more risk of event over time. All right, but there's not a direct, your CAC score is 400, that means that's a 95% lesion. Sometimes, I think that's the way I would think about it. The CT angiogram is very different, right? Then you're getting CAC and you're getting the sort of luminal sort of flow as well, and the diameter there.
Okay, I think that's the last talk. We got some compliments about your talk here. I want folks to remember that code for the CME is good for actually a week. That has been extended to 7 days, or maybe it was always 7 days and I thought it was 1 day. But anyway, and we're excited for next week's talk by Dr. Philippides. Stefan, thanks, really great talk. And this will be up on YouTube like all our other talks. You can search NWMG Lunch and Learn. Everyone have a great Thursday and enjoy one more week of the NFL. See ya. Bye.